Good afternoon. As we know, for antiretroviral treatment programs to have a preventive impact, the proportion of HIV-infected people being treated should be high. More precisely, the proportion of people with detectable HIV viral load should be small. UNAIDS target for 2020 is to achieve viral suppression among 73% of all people living with HIV. Our question is to assess where we are in this target. So the objective of this study, as we can see on this slide, is to measure the proportion of HIV-positive people who were virally suppressed in a community within South Africa with a large-scale heterosexual HIV epidemic several years after the beginning of in-country ART programs. The study was conducted in the township of Orange Farm in South Africa. This township, where there is absolutely no orange tree and no farm, has about 110,000 adults. It is located at 45 kilometers out of Johannesburg. It is similar to many other South African townships. The ART program started in 2005 in this township. The rollout of male circumcision started in 2008, and we conducted a community-based cross-sectional survey in 2012 among a random sample of approximately 3,000 men and 3,500 women aged 18 years or older. Participants were interviewed. Blood samples given by the participants were tested for HIV, for 11 antiretroviral drugs, and for HIV viral load. The laboratory procedures are described on this slide. In summary, for HIV serological testing, we use a sequence of a screening test followed by a confirmatory test. Plasma HIV-1 viral load was determined using a commercial platform, and plasma sample testing positive for HIV were also tested for the presence of the most common antiretroviral drugs currently in use in South Africa. They are listed on this slide. The main outcomes were HIV prevalence, prevalence of any ARV, prevalence of viral suppression, prevalence of detectable HIV viral load, which can be called infectious HIV prevalence. We use here the threshold of 400 copies per ml. It is the prevalence of those who are potentially infectious, the prevalence of detectable HIV viral load. We considered also high-risk groups, about 30% of the sample defined as men aged 25 to 24 years old and women aged 18 to 24-year-olds. Prevalence of dichotomous factors were compared using Poisson regression. This slide gives an overview of the background and behavioral characteristics of the sample. It can be noted that the median age is 32 years for men and 36 years for women. 44% of men and 57% of women are or have been married. The most frequent ethnic group is the Zulu group, and condom used at last sex with non-spousal partner was 53% for men and 54% for women. As you can see on this slide, HIV prevalence was high. It was 17.0% among men and 30.1% among women. The proportion of men having ever been tested for HIV was 59.1%, and when controlling for age, this proportion is 29% higher among circumcised men in comparison with uncircumcised men. The proportion of women having ever been tested for HIV was 79.5%. Among HIV-positive men, 21.0% have at least one ARV detected in their blood sample. Among women, this was 30.5%. Among those with at least one ARV detected in their blood, we observed a high proportion with viral suppression of 29.9%. Among HIV-positive men, 15.5% has a suppressed viral load. Among HIV-positive women, it was 27.0%, and among positive men and women, it was 23.7%. This proportion of HIV-positive individuals with viral suppression was lower by a factor about 2 among those in the high-risk groups. Indeed, it was only 8.4% among HIV-positive men aged 25 to 34 years, and 15.6% among HIV-positive women aged 18 to 29 years. As expected, due to the presence in the sample of people with viral suppression, the prevalence of people with detectable HIV viral load is slightly lower than the HIV prevalence. The main limitation of this study is that we have a restricted description of the cascade of HIV care, HIV testing, ART initiation, viral suppression. Another limitation is that the data in this study has been collected in 2012, and ART provision in South Africa has dramatically increased between 2012 and 2014 or 2015. An advantage of this study is that it is based on a random sample from a typical South African semi-urban community. The first main result is that 23.7%, as I said before, of all HIV-infected people were virally suppressed, far from the 2020 UNAIDS target. The fact that it was about half among high-risk groups is alarming, but at least it is a starting point. Our estimate is close to the 2013 UNAIDS estimate, and the recent published study conducted in Kenya found that 39.7% of HIV-positive people have viral load less than 1,000 copies per ml. The second main result is that ART, when taken, was highly effective in achieving viral suppression. Several factors can explain the small proportion of HIV-infected people who were virally suppressed in our study. One obvious factor is that the South African antiretroviral guideline used in and prior to 2012 did not recommend the provision of ARV to all HIV-positive people. Other important factors are those related to the cascade of care, with the need for better efficiency in every step of the cascade. Can we assess the preventive effect of ART programs in Orange Farm since 2005? It's likely to be low. The first reason is because of the low proportion of viral suppression among HIV-positive people. The second reason is that ART is often given at a late stage. In the poster MOAC0102, we try to answer this question more precisely. We use data collected in 4 independent cross-sectional surveys conducted in Orange Farm in the period 2002 to 2012 among about 11,000 people. We use statistical modeling to disaggregate the effect of sexual behavior changes, male circumcision rollout, and ART programs. We found that ART contributed to a relative decrease in the 2012 prevalence of detectable HIV viral load, of a decrease in comparison to the level we would have had without ART programs, a relative decrease of 6.1% among men and 12.9% among women, which is quite low. I gave this presentation of behalf the co-authors, which are listed on this slide on the left part of the screen. I would like to thank the staff of Orange Farm Project and the Orange Farm community members who made this study possible. Lastly, I would like to thank the sponsor, ANRS, and other funders, and to thank you for your attention.
So, thank you, Burton. So let us take questions. Yeah, microphone 2.
Thank you. Generally, there is a tendency to overlook patients with low-level viremias, but literatures have described that they can progress to AIDS, they can accumulate mutations, and they can also transmit the virus. In your study, were you able to see patients with low-level viremias and how their viral load behaved over time?
No, in fact, we couldn't because it was a cross